Hello, kids, and hello. I hope that this is coming through okay because I had my face melted off in Cleveland. So Nine Inch Nails is my favorite band, and it's one of the best concerts I've been to, and it was really cool. And Nine Inch Nails is awesome, and my face literally melted off the bone. It was great. Had a great time. Cleveland is okay. It's Cleveland. But the concert was awesome. And that's the thing. Like life, kids, is to be lived. So if you have a favorite artist, make sure you go see them. Um, I know finances are what they are, but if you get a chance to go see your favorite artist, go do it. In fact, if you get a chance to go do shit, go do it. Cause we only got so much time on this marble, and we need to make the most of it. So you are not a tree. You can life. Just go live life, and it's really cool, this life thing. So anyway, Nine Inch Nails was awesome. My girlfriend, who was not a Nine Inch Nails fan or like a rock fan, she tolerated it, and we got through it. And she was like, "Yeah, I can kind of see why you like them." I don't know what that means, but she said it. So there's that. Let's talk about drugs today. So we've kind of set the stage, right? So we've kind of set the stage for what let's talk about these substances and actually what they do and how they work and what we do. So today we're going to just talk big picture how drugs work, and specifically how the drugs of abuse that we'll talk about how they work. Now, I'm not going to get into the individual stuff. We will talk about each individual substance as we go along, but of course, there is much bigger chemistry that goes on here. I'm giving you the forest, all right, so that you can kind of understand how some of this stuff works. And it's all quite simple. To be honest with you, understanding the reward pathway of substances is the key to understanding the desirability of them. Now, um, many of you in your first introduction post or even in your schema of addiction paper were like, I kind of don't know how this works, but I had a insert loved one who struggled with addiction, and I'm looking forward to learning more about it. All right. Now, here, and I mentioned this before, and I'll say it again. The question that I ask is not why are you struggling with addiction? It's why are you in pain? Okay. And so we will go to great lengths to not be in pain. Like that's just the nature of how we are as humans. We will go to great lengths to avoid pain. Okay. And so, um, whether it's through a soothing, whether it's through using a substance, using food, using sex, like if we have uncomfortable emotions that we don't like, or we're in physical pain, or we're struggling with stuff, um, then we need to get out of that pain somehow. Okay. And so what can start out as just casual use over time can then turn into something that's habitual. Okay. Very, very few people set out to become a to struggle with addiction, right? Very few people start taking substances with the goal of struggling with addiction or becoming someone addicted. Um, but that happens over time if things are not dealt with. Okay. So let's talk about a few neurotransmitters to kind of get us going. So these are the neurotransmitters that you should know. Okay. You got 6 of them. Acetylcholine is the muscle activation neurotransmitter. Okay. So when you are moving muscles around or things are getting activated, you are releasing or activating acetylcholine. Okay. Or ACH. The next ones you probably have heard of: dopamine, which is our feel good neurotransmitter; serotonin, which is our mood, cognition, and reward neurotransmitter; oxytocin, which is our love neurotransmitter. So those of you that have kids, when your kid was born, that initial thing and the thing that keeps you from like strangling them whenever they do something like put crayons in the DVD machine or in your PlayStation, is oxytocin, right? So whenever we experience love, so the love that we have for our significant other, the love that we have for our kids, the love that we have for our friends, like that releases sort of oxytocin. Okay, that's a neurotransmitter. Okay, it's important in the so we talk about the fight, flight, freeze, fawn. Fawn oxytocin is involved in that. Norepinephrine is our arousal and alertness neurotransmitter. Okay, and then epinephrine is our adrenaline neurotransmitter. Okay. So, if somebody has needed an EpiPen, right? Epi is epinephrine, like if somebody has a peanut allergy, or if somebody has a bee sting and they go into anaphylactic shock, you hit them with epinephrine and that activates the adrenaline, which can open up airways and kind of get things going for them. Okay. So those are neurotransmitters that you need to know. Okay. Now, we're talking about how drugs work. Okay. How does this stuff work with mental health? Okay, so you've heard of SSRIs. That's probably terminology that you've heard before. Well, that stands for, I will do it here, selective serotonin reuptake inhibitor. Okay. Ooh. Okay. So selective serotonin reuptake inhibitor. Now, we're going to talk about this in just a little bit, how reuptake happens and how neurons talk to each other. So keep this in mind when we get there. Okay. But so what happens is that when you have serotonin, which is our mood, cognition, and reward, right? Whether it gets used up too quickly or whether you don't have enough or whatever, you have to have a way to inhibit its reuptake. Okay. So Prozac, Zoloft, Lexapro, some of these that you've probably heard before, they are called SSRIs, right? And so what they're going to do is they're going to select for serotonin and inhibit its reuptake, meaning there's more out there for you to use, right? So if somebody struggles with depression, we kind of don't know why people struggle with depression, to be honest with you, and how it relates to serotonin. We just know that it does. That's why there's like 15 different medications out there to help treat it. Anyway, it's going to select for serotonin, and there's a bunch of different types of serotonin, right? And you can look them all up. It's 5-HT. That's the molecule that we're looking for, right? That's serotonin. There's a bunch of different kinds. So we're going to select for all these different ones and do something kind of different to maybe help somebody not feel as depressed or to feel happier, because there's more serotonin available for them to use over the course of time. Okay. Now there's others that do different things. So there's another medication called Cymbalta. That's an SNRI. So using your context clues here, what would SNRI stand for, right? So selective norepinephrine reuptake inhibitor, right? So why do people struggle with depression? They're down, their mood's low. Well, if we increase their arousal and their alertness, I feel better. I've got more energy. I feel more upbeat. Kind of thing. There's another medication called Wellbutrin that is a NDRI, right? And I'll let you kind of figure that out because that might show up on a quiz. So like these neurotransmitters all do kind of different things. And so these medications that we put out there for people all do kind of different things. But that's what some of this terminology is SSRI, SNRI, NDRI. Like these are all different things that affect these neurotransmitters. So now you know. Okay. So a lot of times people will ask, what is the difference between dopamine and serotonin? Because they're oftentimes used interchangeably, right? So dopamine is released in conjunction with your body's movement towards acquiring something. Okay. It's involved in attention, perception, motor function, and memory formation. And it will increase the feeling of wanting something and helps your body prepare to do what it has to do in order to achieve that. So with dopamine, in many ways, that's our anticipatory response, right? So when I'm getting a feel good, that excitement that I feel, that rush that I feel, that's dopamine. What, like me doing a good workout, that's releasing dopamine. While I'm running, that's releasing dopamine. While I'm eating, that's releasing dopamine. Like I get chocolate, that's dopamine. So I am caught, like whenever I'm doing something enjoyable or whenever I'm preparing myself, in other words, an anticipatory response, that's dopamine. Okay. Now, how does that work in clinical practice? Well, if someone is struggling with addiction, the sort of act of going through whatever it is that they're struggling with, that releases dopamine, right? Like that releases dopamine. So when somebody is struggling with heroin addiction or I guess in this case, fentanyl addiction or opiate addiction, right? They develop, let's talk about just needle use. We'll talk about this stuff when we get to heroin, but let's just hypothetically talk about needle use. So someone is using needle use, right? Well, the entire process from tying off to melting down to drawing out to inject, like that whole process, you're constantly releasing dopamine in that entire process because of that anticipatory reward towards acquiring something, right? And so I'm paying attention to this, and this is enjoyable, and I'm having a good time, right? And I mean, relatively, and I'm engaged in my brain. This is engaging to me. This is releasing dopamine. Okay, so because I'm getting those rewards, I'm incentivized to continue to do that thing, whatever it is. Okay. Now, serotonin is released in response to, again, simply speaking, a state of I'm satiated. Okay. This feeling you get after sexual climax, eating a good meal, that is the release of serotonin. And this is the thing that helps you relax and feel content. Okay. So, and again, we're all adults in this room. Okay. So let's talk about it. This is part of our human and biology. Whenever you experience an orgasm or have an orgasmic response to something, like the anticipation and the act of, so let's say you're having sex, like the act of that is actively releasing dopamine. When you experience the orgasm, that is serotonin. Okay. Now I can use other things like when you're eating chocolate and then after you eat it, but like, I want to make this connect to you. So when you are the experience of something, actively experiencing something is dopamine. The finish, the end, the release is serotonin, right? So those are the neurotransmitters and how they are used. Okay. So while serotonin reuptake inhibitors, antidepressants that stop your brain from clearing out serotonin, are used in managing mood disorders, we have no conclusive evidence, as I mentioned before, that there is any abnormal level of serotonin in people with depression. Okay. So that's the thing about, like, if you've ever had to take an antidepressant or you've had to take several antidepressants or even a mood stabilizer, then it can be very frustrating because you're like, well, what works best for me? If you're interested in that, there is something called genocyte testing. Spell it out, Jordan. Genocyte testing, that you can actually have them run your DNA at a laboratory and tell you what medication would work best for you. Okay. You can talk to your doctor about that if you want. But that is an option available for you if you're interested in what that is, or you're talking with a patient and they've been on several. That's the unfortunate thing with SSRIs and any of those medications. I know this is not the focus of the class, but it's good information for you to know, is that sometimes you have to be a bit of a guinea pig. And that's frustrating to people, especially in recovery, because they're trying to feel better. And there isn't going to be anything, again, going back to this stuff about sex, the best orgasm that you have ever had pales in comparison to the experience of an opiate high. It just does. There is nothing that can match it, right? There is just nothing that can match it, from like its sustainability to like the male orgasm peaks and then we're done, right? The female orgasm can last a little bit longer and you can have several in a row, but like the high of an opiate, oh boy, right? Like that will last for a while. But the problem is that you then start to crave it more, and the window closes a little bit until you get something with a little more potency. So that's where that's where some of this comes into play. So if you've had a family member that has struggled with addiction and you're wondering why, right here it is. it's because of this process. Okay. So let's talk about how cells communicate. Okay. So the goal for our body is homeostasis. Okay. Add your close parentheses. Now, what homeostasis is it's a natural balance. Okay. So those of you with anxiety disorders or have worked with somebody with anxiety disorders or just struggle with anxiety, you may wonder, why is my brain acting this way? Because your brain is doing exactly what it's supposed to do. Your brain is wired for safety. Your brain is wired for balance. Right? Now, sometimes it works a little bit too well. And sometimes those thoughts and the things you think about can spiral out of control because you're trying to come up with everything to keep yourself safe. Right? That's your brain trying to find homeostasis, trying to find a state of rest, trying to find a state of calm. Right? And that's across the whole board. Okay. So cells are communicating with one another to try to find homeostasis in whatever way they can. That's a natural state of rest. Okay. So the cell body is also known as the soma. Okay. So soma means body across, this is the cell body, but across the whole spectrum, whenever we say soma, that means body. Soma, body, soma, body. So if somebody is somaticizing something or their symptoms are somatic, that means it's happening in their body. Okay. It's happening somewhere in their body. So if somebody is struggling with like gastrointestinal stuff and they have anxiety disorders, we would say that potentially that is a somatic response to their anxiety. Okay. Because it's happening in their body. Okay. So then you have dendrites, which are the things that are going to receive messages from other cells. Okay. And here is a big dendrite. Okay. So that's what we're blowing up over here. So this long node here is called the axon. Okay. And that is where the messages are going to be passed. Think of it like an electrical cord, right? So you have your two ends of an electrical cord. This is the actual cord itself. Okay. Now, you have on the outside of the axon is what's called a myelin sheath. Okay. And what that does is it serves kind of as insulation, right? It's the outside of the cord. Now, if you're wondering why people, if you've ever heard of somebody struggling with MS or multiple sclerosis, the reason is because, this sheath on the outside of the axon has degraded, right? And so there are some, cause this is all electricity happening in here. And some of that electricity gets out, right? And it signals to things that shouldn't really be signaled, right? So, if you've had somebody or worked with somebody with multiple sclerosis, that's what's going on, is the myelin sheath has degraded, to where now there are electrical impulses getting out and they can't control, they have involuntary movements. Okay. So at the end, to form junctions with other cells are things called terminal boutons or terminal buttons, depending on how you want to phrase it. Okay. So let's talk more about these terminal boutons. Okay. Now, this is two terminal boutons or buttons like next to one another. Okay. So your neurotransmitter is inside this thing called a synaptic vesicle. Okay. And it's just kind of cycling out here, right? As it works its way towards the end of the terminal bouton, there are openings available for it to receive information. Okay. This end, again, is the axon terminal, otherwise known as the terminal bouton. This is what we're talking about right here. Okay. And this is where all of that information is happening. Okay. Now, we're talking billions of this stuff going on, millions and billions of stuff that's going on. Like, this is a lot of cells we're talking about here. Okay. So don't worry so much about these gated channels. I mean, they're important, but not really. I just want you to understand the basics of how things work. Okay. And so you have these receptor sites, and there's, again, billions of receptor sites that are out there. When you have neurotransmitters that are released, they release into a receptor site. Okay. And so your brain has this thing called neuroplasticity. And that is where it can develop new things and new connections over time. Okay. And so your brain will adapt. Okay. And I'm going to give you an example of that in just a second. So if I'm receiving a ton of a neurotransmitter, then my brain is going to account for that by developing new receptor sites for those neurotransmitters. Okay. So now I have all of these neurotransmitters that are kind of popping up. I need a pen. Draw. Okay, they're going to be yellow. Is this a square? Fine. So imagine these rectangles are new receptors. So I've got all these new receptor sites because I'm accommodating. Well, this is my new standard. Now these receptor sites want to be filled. So what happens if I don't have anything to fill it? Well, now my brain goes, well, where is it? Now I'm upset. Now I'm irritable. Now, I mean, these are the things that are helping me to feel okay. So can you see now why you're like, someone may struggle with addiction in this way? It's all brain chemistry. Your brain, you are training your brain to look for a certain thing because this feels good. Well, what happens when you don't have that thing? Because when you get that thing, you get this release of dopamine, you get this release of serotonin, and it's amazing. And all of your problems start to go away, at least temporarily. Well, what happens when you don't have that thing? Well, now we're looking at like withdrawal. That's not fun, right? Now we're looking at not really having as good of a time. That's not fun. So again, it's kind of chasing this thing that you're training it to do. So let's talk about neuroplasticity. That's happened in my brain, not with drugs, but with like this bullshit, right? Like this, it is really, there was a time in which when I was younger, which by the way, why do we say when I was younger? Literally anything that you say, anything about yourself is when you were younger. Like you can't, like when I was older, I did this, but like, I don't, why do we, anyway. So there was a time in my 20s, teens, 20s, where like I could sit through a movie and it would be fine. But this little stupid box of dopamine and serotonin has made it to where sometimes it's really difficult for me to have like a lull in a movie and not instinctively reach for my phone. I went to go see Weapons. I think I mentioned this to you guys. If I didn't, it was my other class. So I hope it was the other class so I don't feel like I'm repeating myself. But I went to go watch Weapons. And like there were like breaks in the movie where they switched characters. And like I found myself instinctively, the impulse, how I've trained my brain, that when there's a lull, I reach for my phone. Because my brain is like, we need attention, we need something. And it's like, no. So that's been a difficult like transition of like, how do I sit with boredom? Well, that was never a problem before. Books, I love to read. Reading is hard because my brain wants to go, this sucks. Because, right? Because I want the YouTube video that like tells me all I need to know in a YouTube video. Because that's more entertaining. So that's neuroplasticity in a nutshell. And so this is how the process works. Again, high level. Okay. So let's talk about two movements, somatic versus autonomic. So somatic are voluntary movements, right? And then your autonomic are things that are involuntary. So we have sympathetic, which is our fight or flight, which are activated through stimulants. I need to get that off. There we go. And then our parasympathetic, which is the things that are relaxation or state at rest that are activated, which is opioids. Okay. So when we talk about our stimulants, okay, cocaine, crack cocaine, meth, your amphetamines, those are activating the sympathetic fight or flight response. Okay. When we're talking about our opiates, to a certain degree, our alcohols, we're activating the parasympathetic, which is the relaxation or our state at rest. Okay. Let's talk about the limbic system. This is where a lot of work is going to be done. So this is also otherwise known as the midbrain. Okay. So you got four structures that we're going to look at. They are all very important for understanding what this is. So our hypothalamus, which is right here, is our control center. Okay. Its primary function is to keep you stable at homeostasis, which we talked about. It does its job by directly influencing your autonomic nervous system or by managing hormones. Okay. So that's your hypothalamus right there. Okay. Your thalamus or thalamus, depending on who's doing the pronunciation, but your thalamus has several functions going from sensory information and motor signals to regulation of your consciousness and alertness. So it's basically the thing kind of keeping you online, talking about what sensory stuff am I getting, how am I interacting with the world, what feelings am I getting based upon the things that I'm interacting with. Okay, that's your thalamus. Okay, and that's right here. It's a big boy. Then you've got your amygdala, which is right here. Okay, that forms the core of processing your fear response, fearful, threatening stimuli. Okay, this is our fight or flight stuff that I talked about, including detection of threat and activation of appropriate fear behaviors in response to something that feels threatening or dangerous. Fight, flight, fawn, or freeze. Okay, so we can either fight it, we're going to fight back, we can either run from it, we can either go, oh, I love this, or we can freeze. Oh, I don't know. Okay, so fight, flight, freeze, or fawn. Okay. And then our hypothalamus is all about learning and memory. It's where our memories are stored. It's how we develop information. It's how we learn information. Okay. So keep these structures in mind because they're in the midbrain. Now, the closer something is together, the quicker it fires. So you have all these things connected together. So let's talk about how that works before we get to the next slide. So again, this is our control center. It is the central hub of everything kind of going on. Okay. So I've got this sensory stuff going on. I feel overwhelmed. I feel emotions, right? Sensory and motor signals. I'm getting all of this information. If I'm in pain, I'm getting that information. If I'm in distress, I'm getting that information. Okay. And then I've got my amygdala kind of connected in that general area that's processing, should I be afraid of this? Right. So so let's talk about withdrawal, right? I'm getting the sensory information that I'm about to go through withdrawal, right? Now, connected to the hippocampus, what was my first memory of withdrawal? Or what did that feel like? Can I access that? Okay, let me access that. Oh shit, that was bad, right? Now I'm afraid. Now I'm in this thing of like, oh shit, here's what this is about to happen, and I'm not going to like it. And all of that is happening immediately. Okay, that's all happening together. That's what those structures are designed for. So now let's go over to the brain reward pathway. Okay, remember this midbrain? Well, now let's bring it over here. Okay, so this is our VTA, or our ventral tegmental area, which we talked about, I think, week 1 or week 2. This is where dopamine is produced. This is where, when I'm actively engaged in something, I'm preparing for the rewards. All right. That is projected to the nucleus accumbens, which is our treasure box. Okay. And then that goes into our prefrontal cortex, which is where we make decisions, our thinking, planning brain. So let's go back here. All of this shit is activated, right? I'm in a panic because I'm about to go through withdrawal. Now I need to go get the thing, anticipatory response, to make this stuff go away. I know what to do. So here I go. I'm engaged in it. And here's how we know this, because when somebody that was struggling with addiction, and those of you who have, which you talked about your recovery in your post, thank you so much for talking about it. You're going to know exactly what I'm about to say as I say it. But if somebody has made the decision, I'm going to try to be sober, right? And I'm just going to do it cold turkey, right? I'm sitting at home. I'm sweating. I'm talking about mainly opiates, right? I'm sweating. I'm shaking. I'm freezing. I'm restless. I can't sit still. My brain is going crazy. And I just say, you know what? Fuck it. I'm done with this shit. I'm going to go get my stuff. So you call up your dealer, or you call up your boy, or you call up whoever it is, and you point, and then you say, hey, you got some stuff? And they're like, yeah, we got some stuff. But great. I'll be over there in 20 minutes. You hang up that phone, you get in that car, and you're on your way over, and I'll be goddamned if you do not feel better. Every single time. You start to feel better on the way over there because you're anticipating what you're about to get. That's our brain. That's this process that you're already rewarding yourself before you get the reward. Right? You're already saying, I'm about to get this thing that I like, and I'm about to be okay, and everything's going to be fine. And suddenly your body starts to relax because you know that you're getting the thing, right? That's this process. Before you even get the drug, you're already feeling better. That's our brain, right? How crazy is that? And it's all chemistry. This is all what it is. So I mean, yeah, it's kind of cool. At the same time, it sucks that somebody's struggling with addiction, obviously. But like this, it's the brain process that's happening, which is also why it's so difficult to break through. Okay. Because of this pathway. So the more that I do this, the more that I select for it, and the more that it keeps repeating itself over and over and over and over and over again. Right? I'm getting this consistent set of rewards. Remember the Skinner box. I'm getting this consistent set of rewards, and this is a good thing, right? This is a good thing because my brain is getting the thing that it likes. Didn't say it was healthy. It's just the signals that I'm giving to my brain is yes, more. This is good. We do that with drugs. We do that with sex. We do that with sugar. Like we're more and more and more. We're giving our brain the thing that we're telling it that it wants. Right. So let's talk about these are things, terminology for you to know. Okay. We have agonists versus antagonists. So what we're talking about is these are receptor sites. Okay. So this is just a normal receptor site shaped like a upright field goal. Okay. And so when you have I stopped the video trying to get to this. So when you have a molecule or whatever that it can come in and just sit real nice right here. Okay. And that's activating the thing, activating the receptor site. You're giving it the thing that it wants. Okay. You then have things that are called agonists, right? But these are also otherwise known as like imposters. So like it's not really the thing that that you want, but it's mimicking like it is. Okay. So this will be important to remember when we get to medication assisted treatment, because you're going to have things that we call agonists that mimic what the actual molecule is, right? So Suboxone, otherwise known as buprenorphine, naloxone, or if you just want to say Subutex, buprenorphine. Buprenorphine looks like an opiate. Your brain thinks it's an opiate, but it's not. It kind of technically is, but it's a synthetic opiate that mimics heroin, that mimics fentanyl, that mimics oxycodone. It makes your brain think, okay, I'm getting this thing that I want, without the damaging effects, and it lasts a little bit longer and it works differently. Okay. Then you also have this thing called an antagonist, which is a blocker, right? So if you think about to your English lit, right? The antagonist is the person that goes against the protagonist. It kind of blocks whatever progress the antagonist or the protagonist is trying to make. That's what an antagonist is. So something like Vivitrol or naltrexone, even naloxone to a certain degree, but certainly naltrexone blocks the receptor site and prevents anything from getting in. So when it tries to get in there, it bounces off and goes away, and it doesn't get in there. In fact, if let's say that you had an opiate in your system and you were to take a medication like naloxone or naltrexone, it takes that away. It immediately takes it away. This has a higher affinity, meaning like a magnet, like it sticks. Okay. So when I say affinity, that's how do we connect? Like, what is the strength of the connection? So if you have a molecule in here of whatever, in this case, opiates, what happens is that naltrexone or the antagonist will actually remove that and then cap it to where it can't come back in. That's how Narcan works, right? So Narcan works by pulling that off, capping it, but it's only temporary, and then it kind of fades away, and then so people can like actually um, have a relapse of a relapse. When if that's why people have to keep giving Narcans, is because it they can come back up and then they fall back out, and so it's a whole thing. We'll talk about it later, but I'm on a tangent, so I had to go there. But that's how these things work. And we'll talk more about them again as we get to medication assisted treatment. Will be where they're important. But I wanted to give you the terminology now because it's important, because we're talking about how drugs work. Okay, cool. So we've got 10 routes of administration. Okay. Oral, nasal, otherwise known as insufflation, intravenous or IV, subcutaneous, meaning under the skin. That'll be important when we talk about Sublocade. Intramuscular, right, in the arm, right? You can smoke it. It can go rectally. It can go ocularly in your eyeballs. It can go vaginally, or it can go sublingually, okay, which is under the tongue. Okay. That's how Suboxone is taken, is under the tongue. Okay. Here are our drug categories. We're going to go through each one of these, not today, but in future sessions. You've got your stimulants, which are your cocaine, amphetamines, caffeine. You've got your hallucinogens, which is psilocybin and LSD. You got your cannabinoids, which is cannabis, THC, and CBD. You've got your depressants, which is alcohol and benzos. You've got opiates, which is morphine and codeine, and then and others. And then you've got your psychotherapeutics, okay, that are in there as well. Okay. Important terminology: placebo versus nocebo. Okay. So a placebo effect is that I'm just kind of receiving a non-specific effect from a substance. Okay. Meaning sugar pill usually. Okay. So the way that they do drug, like when we put drugs out on the market, they do it with placebo. And that is, they don't tell somebody what they're getting. They just kind of see like, the control group gets basically a sugar pill, and the test group gets the actual medication to kind of see what happens. Okay. But there's also something called the nocebo effect, which is that like I'm going to receive a therapeutic benefit even when something is ineffective. Okay. So oftentimes that happens when like I can tell you. So for instance, you know those copper bands that people wear, right, for like balance or whatever? There's no benefit to that at all. Like none at all. Okay. So placebo is if I just give you the two sugar pills and tell you to take it in the morning and you feel better. Okay. That's placebo. But nocebo effect is even if I tell you that something is bullshit, you believe that it's going to work. Okay. So like those copper fit wristbands, you can, there's that is all pseudoscience. Like that is all snake oil. But yet people will believe and swear that they work. Right. So that's the nocebo effect, right? Is that I got something from it, even when I know that it's ineffective, but it was meaningful to me. Okay. So there's that. You got a quiz. I'm going to unlock it on Wednesday at 6. You have no time limit, but once you start, you got to finish. Okay. So you got to go through it. It's due Saturday by 12, by midnight, 11:59 p.m. And it'll cover everything to this point. It's mostly multiple choice, some fill in the blank, but there's no essays or short answer. 20 questions, 1.5 points each for a total of 30 points. Okay. Reach out to me if you have questions. That's how drugs work. Hope you learned some stuff. If you didn't, that's cool too. We'll talk more. As always, Canadian geese are definitive proof that evil exists. Live mahalo. I'll see you next time. Okay, bye.